right. If you could click it into presentation mode, Liz, and that people can see the full screen. There we go. Perfect. Thank you. All right. Welcome, everyone. I'm Jamie Strauss-Clark, your facilitator. I'm going to do what I always do, which is the quick Zoom etiquette and tech review before we dive into our meeting. We have 2 slides. One is for workgroup members, and one is for our members of the public who are joining as guests today. I'll make this pretty quick since I know you probably all memorized this by now. But for our work group members, please keep your video camera on if you can. Definitely helps us with our collaboration if we can see your wonderful faces. And to do that, of course, you click on Start Video in the lower left corner of your screen. And then please keep your mic on mute. It's already, I think, automatically muted. When you are called upon to speak, you will get that little notification asking you to unmute your mic. Over in the upper right-hand corner, you'll find the view screen options. We always recommend switching to gallery view so you can see as many workgroup members and project team members as possible. And we've, as we have with our past meetings, disabled the chat function because of the large number of people attending the meeting today. We can't really monitor both the chat and the main room. So we've disabled that, but you should still be able to reach HMA Events, your host, if you're having any trouble. We will use the raise your hand to speak function to avoid talking over each other. And to access that, you want to click on that participants toolbar at the bottom center of your screen. You'll get a new window and you can click on that blue raise your hand button. If you joined by phone today, you can do the same thing by pressing *9. And if all else fails, you can wave your hands frantically and one of us will notice you and try to call on you in order. At which time when you get called on, you can unmute your mic. Liz, can you advance the slide for me, please? Thank you. All right, this is for our wonderful public guests. Thank you as ever. I know many of you have been joining us for every meeting for the last 15 months, and we're grateful for your engagement. Please keep your mics on mute, and if you can, your video cameras off. And the reason for this is that we have nearly 100 people joining us today, and it really helps us be able to identify and distinguish between our guests and our work group members if your cameras are off. The exception is during public comment, and I'll talk about that in just a moment. Same instructions as for the work group members on view of screen and the chat function. You may want to put it in gallery view so you can see everyone on the work group, and then the chat is disabled. For public comment, when it's time to make comment, the individuals who signed up to make comments will be called on in the order they signed up. When your name is called, you should turn on your video camera by clicking Start Video in the lower left corner of your screen, and you will be asked, you'll get a little notification to unmute your mic. You can click Unmute then. And then once your speaking time is up, you should mute your mic and turn off your camera again. And I'll go through more detailed instructions when we get to the public comment period. But for now, that's what you need to know. I think we can turn it over now to our wonderful chair, Sue Birch, to do the formal welcome. Sue, you want to take it away? Oh, let's see if I can, let's get her unmuted here.
There you go.
There we go.
I was waiting for you to unmute me. Hello, everybody. It's exciting that we've gotten to this point, especially given the pandemic that we have been in and some of the challenges that we have faced in this process together. I'm very excited that this work is coming to completion, and I think we have really evolved a product that we will get to the legislature, and then we will let them move forward with what they want to do. So I'm just excited that we've arrived at this place. I look forward to the vibrant conversation we're going to have today because everything is still draft. We're just kind of polishing or putting the icing on the cake, so to speak. And so we look forward to the conversation today. And we'll get through this meeting and we'll get the report over to the ledge. And we're just going to keep working on the pandemic and our economic challenges and see where the legislature wants to go with this body of work. So very exciting. I can't thank you all enough for staying with us. I can't thank our consultants enough for shepherding us through, especially the little bomb scare thing that went on in the Capitol. We've had a few unexpected twists and turns, but we've gotten through it. So onward. All right, back to you, Jamie.
Thank you. That might be the understatement of the year, a few unexpected twists and turns, but I sure appreciate it. All right, I'm going to walk everyone through the agenda, and then we will start our public comment period. So our objectives today are first to hear public comment on universal health care, and then we're going to spend the bulk of the meeting discussing workgroup feedback on the report and agreeing upon refinements as needed. Time permitting, we wanted to provide some time, just some unstructured time for workgroup members to have an opportunity to share with each other how you plan to carry on with this work toward universal health care when the workgroup sunsets. And then finally, we'll confirm action items and next steps. So Liz, if you could advance the slide, I'll take everyone through the actual timing. All right, so we've done the technology review and the welcome. And now we're just reviewing the agenda. At 1:20, we'll do the public comment period. Actually, it looks like we're going to be able to start a little earlier than that, which means we can take a few more public comments, which is great. At 1:40, we're going to start our large group discussion, and this is where we're going to be addressing the feedback that we've received from workgroup members and advancing some additional discussions, particularly one around Model C, now that we have Cascade Care Study outcomes. We've allocated about 80 minutes for this conversation, but we've also left the agenda somewhat flexible so that if we need more time, we can take it. In any case, we plan to shoot for a stretch break at 3 o'clock. And then when we come back, Liz, if you could just advance the slide, we will either continue with our group discussion as needed, or we'll move into the breakout groups. And this is when our work group members will have some unstructured, unfacilitated time to talk with each other about how you plan to continue to pursue universal health care moving forward. These will be in breakout rooms, not the main room, but we will be recording and posting those recordings to the website. So it's kind of a hybrid approach where workgroup members get some time together, that we don't have our staff necessarily in the room, but we'll have those recordings up for transparency's sake. And then finally at 3:50, we'll wrap up with action items, next steps, and a little celebration of the work that we've accomplished together, and adjourn at 4 o'clock. Liz, can you advance the slide? All right, so I'm going to do as I always do and take you through where we've been and where we're going. So 15 months ago, September 2019, we came together for the first time and affirmed our charter and decision process, and then spent the meeting level setting on the history of universal healthcare, the terms we're going to use, and then reviewing some alternative models in other states and countries. In December, so exactly a year ago today, believe it or not, we worked on understanding the problems with the current healthcare system. And then in February 2020, our last meeting in person together, we developed the assessment criteria by which we've considered universal healthcare models. And then, as you all know, we had to postpone, I guess, that April 2020 meeting. Liz, can you advance the slide, please? Thank you. In June of 2020, we had our first digital meeting where we discussed and refined 3 draft models for universal health care delivery to be analyzed by our actuaries. And then in August 2020, we assessed our 3 models of universal health care delivery using agreed upon qualitative assessment criteria. In September of 2020, we assessed the draft models using quantitative criteria. And then in our first of 2 October 2020 meetings, we focused on the operational and regulatory steps that would be needed to implement universal health care. Liz, if you could advance the slide. Last meeting at the end of October, we discussed and agreed on some end goals of universal health care and transition steps, how we would go about implementing this. And here we are, December 2020, and as I've said earlier, we're going to be reviewing your feedback, workgroup members, on the draft legislative report and make any final adjustments to the recommendations as needed. So that concludes this portion of the discussion. Liz, if you could advance the slide, we'll talk about the public comment period. So we're able to move into public comment a little bit earlier, which is great because we have 57 people who signed up to make comments. That'll give us time to take as many people as possible. All of our folks who signed up to make public comments received an email with these rules, so I'm not going to go through them one by one, but just a reminder that we do have some rules for public comment. Today, because of the large number of people who signed up, I'm going to use my discretion to reduce the time allocated per comment. So each person will have 90 seconds to make their comment. There will be a timer on the screen, and I'm going to be strictly enforcing that time. So please make sure that you are done talking when your minute and 30 is up. You'll hear a little chime. And then I will have to interrupt you if you continue talking and possibly mute your mic. So please do, out of respect for other people who are signed up to make comment, please do wrap up your comment right at that 90-second mark, if not before. We're going to call on folks in order that they registered. If you do not get called on today because we've run out of time, please remember there are other ways to provide public comment, and the work group sees all of these public comments, whether written or verbal. You can submit your public comments via email using the HCA Universal Healthcare email box that's on our website. Also, those of you who make comment today, if you have written versions of your comments, it helps if you can submit those so that our work group members can also read them. So please find that email on our website and submit your written notes. All right, I'm just going to show you the list of folks who signed up to make public comment. They received this list yesterday, so they should be knowing where they fall on the list. Just a couple of notes on this page. Actually, one note, which is Lisa Chappelle, who signed up as number 14, is not able to get on the screen today because for health reasons. So Jen Nye has offered to read her public comment on her behalf. So it'll actually be Jen Nye on the screen reading Lisa's public comment. Liz, you want to advance the slide so we can see who's number 21 through 40? We'll just take a moment to let everyone remind themselves where they fall. And then one more slide, 41 through 57. Great. Okay, so if you could go back, actually you can stop sharing. I'm going to share my screen with a timer in just a moment, but the first person to comment today is going to be Kevin Wren, followed by Marcia Stedman, followed by Maureen Brink-Lund. And as ever, I'm going to be reading 3 names at a time. So be prepared to unmute your mic and turn on your camera when you are called. Bear with me just a second. I'm going to share my screen with my timer. Actually, let me just try that again because I need to put the sound on it. Apologize. Here we go. Okay. Okay, so let's start with Kevin Wren. Kevin, when you're ready, you can start talking and I will start the timer.
Thank you for your work on urging the legislature to provide universal health care in Washington. From the conversations I've heard, these meetings, there's consensus for option A. There is a small minority who are concerned with feasibility, but this is overshadowed by the other members as well as patients who support option A. Our state is capable of providing publicly funded universal health care for all. The small minority could compromise with the other board members and members of the public who support option A. I think we can make it clear option A is the great path forward, and we should make a strong recommendation to the legislature. Please make the consensus clear and strongly urge a recommendation to the legislator that option A is overwhelmingly supported by members of the work group and public. Affirm your position on option A. The disabled like me, Black, Indigenous, and people of color, LGBTQ+ communities face disparities and social determinants in health. Option A can help us mitigate those injustices. Please include our voices. Thank you.
Thank you, Kevin. Okay, next up is Marcia Stedman, followed by Maureen Brink-Lund, followed by Cindy Laws.
Thank you for this opportunity. Okay, thank you for this opportunity to speak, and thanks to Optimus's data, we know that Model A meets 6 of the 7 goals of a desirable health system, having been declared deficient only in feasibility. Feasibility is the ease, possibility, or likelihood that something will be done. Declaring the best option impossible or unlikely without considering ways to make it possible is to fall short of meeting one of the work group's charges to consider options for ensuring a just transition for those working in the current healthcare system who will be affected by a system change. Businesses, healthcare providers and facilities, hospitals, health carriers, state agencies, labor, and so on. This work group has run out of time to consider how we get from the here of our current dysfunctional system to the there of a system that is easier to manage, at lower cost, and with better health outcomes statewide. Fortunately, our state has existing universal healthcare legislation that addresses the need for a just transition as well as other concerns. The Washington Health Security Trust Bill, HB 1104, enables the establishment of a universal healthcare system in Washington and includes a worker retraining account for retraining and job placement of workers displaced by the transition to the trust, in effect for the first 2 years of the trust. The main charge of this work group is to recommend the system we need now, one that brings all Washington residents the healthcare they need and deserve. That is clearly Model A. Thank you.
Thank you, Marcia. Next up is Maureen Brink-Lund, followed by Cindy Laws, followed by Chris Curry.
Hi, thank you.
You can go ahead when you're ready.
Okay, thank you very much for your time. And my name is Maureen Brinkland. I've lived in Washington State for 48 years, and I currently live in Ballard in the 36th district. I care about achieving universal health care for reasons of equity and justice. Good health is affected by much more than just health care. After following this work group process by attending several work group meetings this year and listening with interest, I wholeheartedly support option A. The numbers plainly show us that it's the only option that ensures access to healthcare for all residents of Washington State and saves millions and millions of dollars in the process from day one, with increasing savings over time. I would like to know, for the record, which option each of the work group members supports and why that is. Thank you very much, and thank you so much to the work group for your hard work.
Thank you. All right, next up is Cindy Laws, followed by Chris Curry, followed by Chip Boyd.
Happy holidays, everyone, and thank you for your hard work on this measure. I always think it's important to go back and remember what the legislation was, and the legislation required us to put forth a pathway. That pathway has been solidly with Model A. And the important part in this Model A is the cost savings. It is so important when we look at saving $5.6 billion in years 2 onward per year in spending. That spending on healthcare is going to be able to allow the state to invest in other ways. Meanwhile, there are people clearly looking as that Cascade Care will save us. And it was clear from the testimony. When one reviews the testimony from legislators and people testifying on behalf for or against Cascade Care 2 years ago, back in February of 2019, is that Cascade Care was itself just a Band-Aid. It was just a Band-Aid. And when you leave a Band-Aid on too long, the skin underneath it dies. Cascade Care is helpful, but it is not the end-all to be-all. The state of Washington has grappled with funding healthcare for all of its residents since 1987 with the Health Services Act. Let's please reinvigorate that effort. We've done so many more things with so much less urgency, building baseball stadiums, bailing out Boeing. Protecting the public is our most fundamental importance in the state of Washington, especially during a pandemic. Your work is done.
Thank you, Cindy. Next up is Chris Curry, followed by Chip Boyd, followed by Clark Gilman. Chris, you can go ahead and start speaking when you're ready.
My name is Chris Curry, and I'm a retired RN in Spokane. I have closely followed these meetings, and I am still very dismayed by the idea that no single recommendation will be offered, despite the fact that the budget proviso requires recommendations. No work group member has publicly said that they prefer options B or C over option A, and most seem to strongly favor option A. So what is the problem with recommending it? We are facing a crisis, and our legislature desperately needs a specific plan that this highly qualified group is expected to offer. Instead, the draft report has stumbled over the feasibility issue, a concept that was not even mentioned in the legislation. While it should be considered, feasibility is a very subjective and can change from moment to moment. It even improved greatly just 5 weeks ago. So there is no need for it to receive a red flag warning, especially in the executive summary. Too many legislatures will only read the summary, and if option A is portrayed as infeasible, which it most definitely is not, they will certainly not look any further into it. What is most needed at this meeting is for each workgroup member to briefly explain their personal conclusions and express whatever observations they might have regarding the superiority of option A. Then each member should vote on their preferred option with the results included in the summary. Thank you.
Thank you, Chris. Up next is Chip Boyd, followed by Clark Gilman, followed by Mary Williams. Before Chip begins speaking, I'd like to remind our members of the public, if you could please turn your video cameras off. It does make it easier for us to both find who is going to be speaking today and also make sure we can track who's in our work group. So if you could please turn your video cameras off by clicking the stop video icon in the lower left. Actually, it would be right now up on the top center of your screen. That would be much appreciated. Thank you. So Chip, you can go ahead and start speaking when you're ready.
Amy, I don't think Chip is with us. I haven't found him.
Okay. Okay, then let's go with Clark Gilman, followed by Mary Williams, followed by James Cooper.
Great. Thank you for this opportunity. My name's Clark Gilman. So who's this Johnny come lately, right? I serve on Olympia City Council, and we raised our family on 100% employer paid full family coverage. As a Carpenters Union organizer, I guided families in the transition from the uncertainties of charity care to comprehensive health coverage. So I really believe that the universal health care is a powerful tool for unlocking human potential and creating a more just and humane Washington state. In my experience on city council, we often charge boards and commissions with studying an issue, seeking community input, and making recommendations to us. And there is often a reluctance to make a specific decision to send a very specific recommendation to council. So I believe that groups like this work group are the strength of our democracy, and I urge you to report back to the legislature with specific recommendation. It's appropriate to document the range of discussions and perspectives, but to make a focused recommendation to the legislature as you were charged, I think is so important to keeping this ball moving forward. And I just really want to thank you all for the time, energy, and wisdom you've contributed to this effort. Thanks.
Thank you, Clark. And I'm just going to make a quick note. I got a note from James Cooper, who's going to be withdrawing from making comment today. So up next is Mary Williams, followed by Michael Benefiel, followed by Sarah Moore.
I think we're missing Mary as well. I have not found her.
Okay, then let's go with Michael Benefiel, followed by Sarah Moore, followed by Chris Kevorkian. Michael, you can go ahead and start speaking when you're ready.
And Michael was on here earlier, but I don't see him either now.
Okay. All right, let's go with Sarah Moore, followed by Chris Kevorkian, and then Jen and I will be reading the comment for Lisa Chappelle.
My name is Sarah Moore, and I live in Burien in the 34th District. I support option A. I'm new to this group, although universal healthcare has always been important to me, and I've been following along with this conversation. I want to tell my personal story, which is that of a supervisor in the painful position of implementing the layoff of my entire team during a pandemic. I made every effort to work with my team during the long paycheck protection period when they were transitioning, earning a wage, but transitioning into unemployment. And I tried to find out what they needed and do all that I could to provide it. I want to reflect on the degree to which the anxiety that they felt was experienced around loss of medical coverage, which was a far greater, deeper, and more impactful than the loss of income for every single one of them. Their medical insurance supported spouses, children, supported their prescription medication and their ongoing treatments for chronic conditions. The COBRA offerings were burdensome, and buying insurance was also challenging for them. And all, including myself, were left in positions to make decisions about their future in a much tighter time than they could have done if they had had access to health care during this time. Universal health care is not a luxury, but a need. Thank you for the opportunity to speak.
Thank you. And we found Michael Benefield, so he'll go next, followed by Chris Kevorkian, followed by Jen Nye, who'll be reading on behalf of Lisa Chappelle.
Okay, thank you. I am Mike Benefield, PCO for the 23rd Legislative District. Model A provides affordable and comprehensive universal health care for all. Model B may improve the health care coverage for some in the state, but will not provide affordable and comprehensive health care for all. Model A saves over $2 billion in the first year, while Model B saves less than $1 billion. The difference of this $1 billion in the first year and up to $4 billion in future years goes to healthcare industry profits in lieu of providing affordable health care to residents. Model A favors the people, while Model B favors the healthcare industry and does not meet the goals of this work group. Model A provides the universal health care that the work group was tasked in finding and should be the only recommendation in the report. The preliminary report says that the work group made no effort to determine the feasibility of Model A, and yet a lot of time was spent on Model C, which will provide no help at all for most of the residents of the state, who will raise the total cost of health care for the state. Model C should not be included in the report, only Model A. Thank you.
Apologies. Up next is Chris Kevorkian, followed by Jen Nye, who'll be reading on behalf of Lisa Chappelle, followed by David Loud.
Thank you. 10 years ago, I was teaching at a university in England and helping the NHS create modules for medical professionals on end-of-life care. Later in 2010, I returned to the US because both of my parents ended up hospitalized on the same day. My father had a heart attack and my mother thought she had food poisoning, but ended up on life support despite having advance directives stating no life support. No one bothered to look at that section of her medical chart. 6 weeks later, my mother died from acute pancreatitis. The medical bill was over $260,000. We had to cover $11,000 of the cost, but thankfully we could. Pre-COVID, I used to lecture at local libraries and senior centers about end-of-life care and the costs of caregiving. Most people have no idea that health insurance doesn't cover caregivers or long-term care when someone is dying. And sadly, they don't prepare for these situations. I teach as an adjunct professor and pay for what is known as catastrophic medical insurance. I'm basically working to pay the cost of health insurance with a high premium and high deductible. My colleagues in the UK are safe to switch careers or create their own business without fear of going broke because of a medical event. The US feels like an oppressive country that doesn't allow people to thrive and spread their wings. We should all have universal health care. I thank you for all the work you're doing, and happy holidays.
Thank you, Chris. Up next is Jen Nye reading on behalf of Lisa Chappelle, followed by David Loud, followed by Pamela Nygaard. Jen?
My name is Lisa Chappell. 90 seconds isn't long enough to tell my full story, but in 2018, I was living my life happily, buying my beautiful Victorian home, blessed with friends and neighbors, and active in my community. I had Molina insurance, but Molina pulled out of Grace Harbor County, and I had to change to Amerigroup. Amerigroup refused to pay for a medication I'd been taking for years. The new medication Amerigroup paid for nearly killed me. I had an autoimmune reaction to it, and my skin began to blister and peel off from head to toe. On June 19th, 2018, I went to the ER thinking I'd be back home in a few days. Now, 2.5 years later, I am trapped in the hell of institutional living. Prior to my current situation, I lived in Paramount Skilled Nursing Home where I endured so much abuse and neglect, I'll never have the tools to process it all. Paramount was ranked in the worst 50 nursing homes in the country, and in part to my account, it was closed. Now I live in an adult family home in Auburn. I live in one room. The light from the window is blocked by a tree. I sleep 18 hours a day and think about death constantly. I've lost it all. My home, my cats, my autonomy, my dignity. Because AmeriGroup wanted to save my medication, the state now pays $7,000 a month for the unforeseen future to restore me. Still, my inner activist is asking all of you here, all that can hear my words, to be heroes and make sure this doesn't happen to anybody else. Thank you.
Thank you, Jen. Okay, up next is David Loud, followed by Pamela Nygaard, followed by Catherine Brown. David?
Yes, thank you. Dear work group members, we're counting on you to fulfill your mandate to recommend how our state can create a truly universal and affordable healthcare system. Healthcare is a Human Right Washington joins many of you in favoring Model A, which is clearly the most economical overall. We know you have differing views on this, but it is important for each of you to go on record with which model you do support. Otherwise, the work group will not really have a voice in the outcome, and all your work will just gather dust on some virtual shelf. That's not why 500,000 taxpayer dollars have been spent. And please be bold. Feasibility has been suggested as a reason against recommending a universal system, and Model A in particular. I think this represents a self-fulfilling prophecy. In the face of our public health, economic, and racial equity crises, is it feasible not to establish a clear goal to guarantee affordable health care to all Washingtonians? Of course it will take time. Of course we will need more federal help. Please set a goal so the legislature can design steps to get there. And then let's all persuade Congress and the Biden administration to provide the help we need. Thank you for all your work, and staff too.
Thank you, David. Okay, up next is Pamela Nygaard, who will be joining us via audio, followed by Catherine Brown, followed by Sherry Lambert. Pamela?
Thank you very much. My name is Pamela Nygaard with Genexia Health, and it's a pleasure to be here today. I want to say thank you to everyone. This is a really big problem that we're tackling, and you are setting the stage for the rest of the United States. So huge kudos to everyone working on this. I just want to say that I know that we're obviously attacking the access, cost, and quality in looking at this problem, which is, of course, the ultimate goal. And I just wanted to add a thought that we keep in mind patient empowerment in the process and ensure that good tools and everyone has access to them, such as telehealth, dietitian, mental health, and decision tools for people at home. Obviously, good outcomes will create even lower costs and a higher satisfaction in the long run. And we certainly don't want anyone going postal in this process as we're on the path to better health. So thank you for all of your efforts and your work. And thank you for keeping good health and good decision tools in mind. That is all.
Great. I think we have time for 3 more comments. So up next is Catherine Brown, followed by Sherry Lambert, and I think we'll finish with Joseph St. Alban, although we'll see what the time looks like when we get there. So Catherine? Sean, were you able to find her?
Yep, she was here. Sent her a message.
Okay, why don't we try Sherry Lambert and then we can come back to. Did you say something?
And Sherry was here and Joseph was here.
Oh, I think it looks like Catherine raised her hand, so maybe that can help. Oh, there she is. I will unmute her. I see her.
Okay.
Catherine, are you able to unmute there?
Yes, finally. Okay, I was sort of
Great.
kind of his pitch pond there trying to unmute. Thank you. Okay, well, I did await Cascade Care thinking finally something was being done to rein in the cost of health insurance premiums. There's a mandate in the bill requiring this to happen. My healthcare premiums actually have gone up $200 this year, which is the worst one-year increase I've experienced. And in contacting Kreidler's office, I got a placating response. So Cascade Care is clearly not the answer. My husband's working in Vietnam and can't come home because we can't afford to bring him home because of insurance. So I've lived without my husband for 3 years as we struggle to pay the small amount or the premiums that I am attempting to pay with the healthcare that's available to me. Meanwhile, I'm almost 60 years old and I can't seem to find a well-paying job, even though I do have a master's degree and a career, but apparently people don't like to hire 60-year-old women with some health issues. So meanwhile, the rest of the world looks on with a mix of disbelief and derision at what we've created in the name of greed and hard-heartedness. It is my hope that this darkest hour, when so many Washingtonians are in these dark situations of not being able to find care and not being able to continue losing their homes and losing everything, it is my hope that this is what it will take in order to provide the light needed for compassionate design of a single payer system that is not private.
Thank you. Thank you, Catherine. Up next is Sherry Lambert and then Joseph St. Aubin, and then I think we're going to be out of time. So Sherry?
Thank you. My name is Sherry Lambert and I'm in Bellingham, Washington. And to really have equity in our healthcare system, we need a universal system that eliminates insurance companies and pays all medical expenses for all residents. I worked as an X-ray tech in both clinic and hospital settings in the 70s and 80s, and healthcare costs were within reason. But in the 90s, as technology expanded, healthcare costs began to explode. I believe that is when profiteering from the system became the mode of operation, and the waste in the system was very obvious. Insurance companies began to control how medicine was practiced. While one bookkeeper in a practice was normal, now physicians and hospitals needed several bookkeepers, someone to deal with Medicare, someone for Medicaid, et cetera, et cetera, et cetera. The amount of time wasted fighting denials is disgusting. This puts a heavy burden on physicians, and the added paperwork and hoops they have to go through is lost, unproductive time that could be better spent on patient care. Some insurance executives are earning more than $20 million a year in salaries, bonuses, and stock options, many more times than a physician would ever make treating patients. This is a complete waste of healthcare dollars. I'm always amazed at how many people can't wait to be 65 to be on Medicare. And why wouldn't they want that for their children and grandchildren? Thank you for your work.
Thank you, Sherry. Okay, and we'll finish with Joseph St. Aubin.
Hello, members of the committee. My name is Joseph St. Aubin. I've appeared in front of your committee numerous times in support of option A, of which I still do support and believe that should be your recommendation to the legislature to implement a universal health care program for all Washingtonians. However, today, I'm here to raise a different issue, namely access to committee meetings that would normally be held in Olympia. The pandemic has shown that it is possible to hold committee meetings such as these through the internet. Access is the key issue that confronts most physically disabled people when attempting to participate in committees like these. Had this committee been meeting on the internet from the beginning, it would have been possible for me and / or other disabled people to serve on this committee. Going forward, I strongly urge that all future meetings coming forth from the Washington State Healthcare Authority be made virtual so that no one's voice is silenced ever again. Thank you for the work your committee has done, and thank you for allowing me to speak with you today.
Thank you. All right, this concludes our public comment period. Thank you everyone who took the time to make a comment today. And again, a reminder, if you have written notes, please send them to the HCA mailbox and we will make sure that our work group members see them. Also, if you were not called on today because we ran out of time, please do submit your comments. We will make sure, as I said, our work group members see them. Now we're going to move into the main part of our discussion. As I mentioned earlier, our objective today is to discuss the feedback that we received from work group members on the draft reports, and in particular, some areas where we identified either needing to report back to or acknowledge the feedback that we heard and how we're addressing that feedback, or some areas where we need some further discussion as a group. And so I'm going to turn it over to Liz Arden, who's going to walk you through some of those issues. Before I do, I see Dr. Weinberg has her hand up. Dr. Weinberg? Oh. Hold on, I just lost you on my screen, so I can't unmute you. Does anyone from the host team able to pull her up?
I think it says I'm on mute. Can you hear me now?
Oh, there we are.
Okay.
Yes, we can hear you now. Thank you.
Before we leave the public comment period, I just want to note that every single one of them urged us to support Model A. We need to remember that fact. Thank you.
Thank you, Dr. Weinberg. Okay, Liz, you ready to go?
Sure. And please let me know, Jamie, if somebody raises their hand or something, because I only have one screen and I can't see anything except the slides. So,
I will
everybody.
be your wingman.
Okay, thank you. We just wanted to spend a little bit of time talking about some of the feedback we heard on the report globally, and then also spend some time on the things that we need to address in that feedback together. So just to sort of recap for everyone, we heard responses to the draft from about 7 or 8 people. And the areas of feedback that we heard are largely grouped into those that were editorial or content, which are being incorporated into the next version. And then those that we consider more process oriented, which is what we're going to spend some time on today. First, the issue of work group member perspectives, facilitator follow-up conversations, and then wanting to hear a bit more about Model C. So just to kind of explain to you how we grouped all that. Okay. So again, these are the 3 things that we're going to spend our time on today. First, I want to just share with you, and we heard this today in our public comment, we know that there was some reaction to not seeing enough in the report about hearing about the work group perspectives and conversations focused on cost sharing benefits and population, and how those conversations influenced where we got to with our 3 models. So we will be deliberately going back through our summaries to pull in more of those conversations and reflect the dialogue that was going on in our development. We also heard a lot from folks, from the folks that responded, that they want to hear more about what work group members think about the models that have been discussed. And again, this is what we heard from a lot of our public commenters today. So we appreciate your sharing all of that. And thanks to some suggestions from some work group members, we have developed a survey to help take the temperature of the work group. And so we'll be putting that out to you during our meeting today. We've tried in the past to do surveys with folks, and the response rate hasn't been super great. So we are building time into our meeting today, where we're going to be asking you all to please provide some input on what you're thinking. And these are the questions that you will encounter in the survey. I just want you to know what they say, and you'll see that there's an option to abstain from completing the survey if you are unable to participate because of your role as a state employee or for any other reason. So there is an opportunity to do that. And if you do say, yes, I abstain, you will leave the survey. And then you'll be asked to rank these models on a scale of 1 to 3. And there is an option to say, I don't have enough information, or none of the models as well. So we've heard your concerns, and we will be reporting that information in the next version of the report that you get. So we also know that folks wanted another opportunity to review the report once we make these changes. So we are going to make accommodation for that, and I'll talk a little bit at the end about our timeline for that. So we also know that there's been a lot of question about Model C, but actually I just realized I skipped over something. The next issue that we heard some concerns about was the conversations that were follow-ups with individual work group members. And so I'm going to turn it over to Jamie to speak to that a little bit.
Hi, everyone. So I wanted to take a moment to acknowledge a concern that was raised from some of our work group members. And I also heard in a couple of public comments at past meetings. And that was around the one-on-one discussions that I have with work group members. So I want to take a moment to acknowledge that concern and hopefully assuage it. So throughout the 15 months that we've been working together, I've extended invitations to any work group member who wants to debrief with me before or after a meeting that they're going to miss, or to follow up on a specific discussion topic. And many of you have taken me up on that. I've had really wonderful conversations with so many of you throughout the year. As we shifted to virtual meetings, I indicated that I would be reaching out to work group members who had missed meetings or maybe aren't speaking up quite as much in meetings, just to make sure that we're hearing all perspectives. And I do understand from feedback that I've heard that this raised some concerns about transparency. So I want to take a moment to acknowledge and hopefully assuage it. In all cases, my conversations, my one-on-one conversations, were focused on either clarifying points that were made in work group meetings, or encouraging that work group member to share any concerns or perspectives that they have with the work group at the next meeting. But most importantly, nothing in the report reflects, the report reflects only public work group deliberations. Nothing in that final report or meeting summary reflects information that was shared privately. The private conversations were primarily meant to encourage more engagement and sharing at the public level. So hopefully that helps address any concerns about transparency. I'm going to turn it over back to Liz.
Thanks, Jamie. Before I move on, there was a comment that came in from Aaron Katz about how he wants to be able to rank more than one. There is an opportunity. There is a free form text box in the survey, so you can put additional comments in there. For example, if you're interested in, 2 of the models, you can rank them in your order, but then put a note in the free form box. So please, there is an opportunity to do that. So, and just to reiterate, the results are going to be shared not in like an aggregate format, like 30% of this or whatever. It's really just to take a temperature and provide what do individual members think about the different options that have been put forward before them. So, and we'll come back to that at the end of this discussion, where you'll have time to go straight to the survey. Okay, so, oh, there's Bevan, go ahead. Bevan, you have a question?
Okay, I'll find her and unmute her.
Okay.
Okay, can you hear me?
Hold on.
Yes.
Okay.
Oh, yes, we can, thanks.
Just clarifying question. So we're doing the survey, and then is there a reason we wouldn't reflect the results of the survey in the executive summary?
Well, we will just probably mention in the executive summary that we took a poll of folks to get their perspectives. We just really want to hold to the understanding that this is not a voting body per se. It's more of, these are the perspectives. So I think we can talk a little bit more about that when we get the next draft going, Bevan, and get the executive summary written. But we will have a place in the report where it captures individual perspectives. Erin?
I would just think as a legislator, if I'm looking at the executive summary of this report during a really busy legislative session, to get a sense of like, hey, maybe 30% did support option A, and maybe 90% support option B, right? Like I think that that's a great space to understand as a policymaker how we might get to universal healthcare by 2027, right? Like I hope that we can reevaluate that decision.
Okay, thank you. I saw another hand from Aaron.
Yeah, I just, following up on Bevan's point, I just want to, I think the perspectives of the work group members, if we don't have a vote, that's fine. If there's not a tally, that's fine. But it seems to me, especially what we've, both what's in the charter and what we've heard in the public comment, that our perspectives, our individual perspectives are kind of critical. That, even if it's just a table in the executive summary.
Okay.
I mean, so that elevates the voices to the extent that I think is called for by the proviso and our sort of marching orders.
Okay, thanks for that suggestion. I think that we're definitely going to be putting a table in the body of the document. It's trying to strike the balance of having the length of the executive summary, but that type of approach could make sense. So thank you for that recommendation.
Liz,
Vicki?
can I just jump in for a sec?
Sure.
Wait, Liz, can I jump in for a quick sec? Sorry, I don't have a raise my hand function. I think what I'm hearing from Aaron and Bevan is we need some kind of at-a-glance tool for busy legislators who are not going to go through the whole report in detail. So I'm sure that we can come up with a solution for that. Not necessarily off the top of our heads here, but I think Aaron's idea of a table makes sense, and we can consider how to do that. And I'll unmute Vicki now.
Well, that rather covers what I was wanting to say, is that if the legislators don't get that information from the work group members, you've kind of wasted our time. So I think it's really important that it be in a place where they're able to see it, because there's so many years of experience, expertise, and knowledge here. And I think that is, the idea of having a work group. I'm used to, in the tribal world, we would make sure everybody's voice was heard. And so I was a little surprised that wasn't reflected in the report. So I'm happy that you're doing the survey, but I really think it's important to have not wasted our time and make sure that the legislators get to hear what we each think. Thank you.
Thanks, Vicki, and thanks for your recommendation. So I appreciate it. Okay, so moving on to Model C. This was another substantive area that we heard from a couple of folks that they wanted to hear more about. And, really just looking back, we spent a lot of time on models A and B, and Model C is really an alternative pathway to universal coverage. It's not a single payer system. It's not in the same spirit of Model A and B, but it's more of building on the existing infrastructure to get to universal coverage. When we took the approach on Model C, we focused on modeling the cost of coverage for a population with limited or no coverage undocumented immigrants, because at the same time we recognized that there was another work group, the Cascade Care Subsidy Report work group, that was working on another one of these key components. And we now have information from that work group, and we're going to talk a little bit about that and what the impacts mean for that, for the remaining population around. But there's also a number of policy steps that could potentially be taken in the spirit of Model C, while at the same time working on delivery system reform. So we're going to just spend a little bit of time on that today. And I'm going to turn it over to Jared Nason from Optimus, who's going to talk a little bit about some of the details that we have in light of the Cascade Care report. And we do have Joan Altman from the Exchange here as well to answer some questions, and then focus a little bit on the other component that we costed out within our work group, which was the coverage for undocumented immigrants. So go ahead, Jared.
Thanks, Liz. Appreciate that. So what this slide is at a high level presenting is just a takeaway from the walkthrough that Liz just did on the prior slide. It just puts some numbers and some costs to the two options that were more or less modeled out. At a high level, we talked about there's two components. There's the subsidy, Cascade Care subsidy, and then the coverage for the undocumented immigrants. And as you can see, at least in the slides, what the estimated cost of the program is, some of the parameters of the program, are, as well as the number of people that would be impacted through the options. I do want to note that at least for the adoption or the subsidy, those were developed as a range. So what you're looking at on that slide more or less represent the upper bound of those ranges. They do range down at the low point. Instead of 24,000 uninsured, the low range is 14,100 about, and the cost is about $101 million. So there is a range around those subsidies. But again, the intent there is to more or less provide subsidies for some of the lower income individuals who are purchasing insurance through the exchange and the public option. Whereas the second and the most expensive component, I guess, from a cost perspective, are the coverage for the undocumented immigrants. And so what you can see there, and I think we presented this in some of our previous presentations, as well as detailed it in the draft of the report, is that this is intended to provide coverage for undocumented immigrants. As we mentioned, $617 million in new costs. But I do want to point out, as it pertains to $617 million, is that to some degree, there are costs, although the current utilization and the cost of the undocumented population inside, say, Medicaid through emergency services or other state funds that might go to provide the care, they do exist. They are represented in our status quo. We just cannot, for a lack of a better term, tease them out of the $617 million that we have estimated here. So having said that, you can see here that this program is intended to provide coverage through a system, an insured system today, where insurers provide the network development, pay claims, et cetera, and administer the program. But as you can see on the slide, these are the costs and the number of folks that we would expect to be impacted. As we move forward,
a good time to take questions? Oh, sorry.
Sure. I can't see. I also
Okay.
can't see who raised his hand. So.
Oh no, don't worry. I'll take care of it. I didn't want to interrupt your train of thought. So Dr. Tritko, followed by Kelly, have questions. So Dr. Tritko.
So under the subsidy program, it would cover 24,000 people who are residents and uninsured. There are 560,000 people who are currently uninsured. Now, we don't know how many of them don't qualify for Medicaid. I suspect quite a bit. A lot of them would probably qualify for a full subsidy under federal subsidies. Also, for the undocumented immigrants, I thought there was more like 170,000, not 124,000. But I say that to say this. If we would just account for all of those people who are currently uninsured, we could finish Model C. It wouldn't take a lot of time. I just don't know why the resistance to make Model C far more complete and give the legislature an option next year to get really close to universal access while we're trying to think about how to make B and C feasible. But this is how you would do it. Let's just add up what the numbers are. Let's see what it costs, and let's throw that out. Thank you.
Thanks. And
I'm just going to jump into, thank you, Dr. Tritko, we're also going to take some time after we go through this presentation to discuss. So definitely please raise your point again when we get there. Sarah, did you want to respond to, sorry, I apologize for interrupting. I just want to make sure everyone knows that. Go ahead.
You're fine. Thanks, Jamie. No, I was actually going to point out that we will get into a little bit of that discussion as we go into the next slide. So thanks for your comments.
Okay, so Kelly, let me unmute you. There you go. Go ahead.
Hi, yeah, I just wanted to share some real world costs that are coming down. So my family just signed up for 2021 healthcare on the exchange, and you can see our cascade. I think you can see, I'm not sure what you can see of the background on my Zoom. But that is what we are paying every month and every year. So actually, could somebody, it's like $27,000 a year. And that's for 3 of us. And of course, we are older. So that definitely, Pam McEwen mentioned that when you're older. It's very expensive, and well, she's right about that. So I really need people to understand that the unaffordability is just crushing, and that, I mean, my husband and I joke that we need insurance for our health insurance at this point, because even using it is another burden. And I also just wanted to say that while Cascade Care has helped, I am thankful that the deductible is definitely better. It's just these premium costs are crushing, and we're having to go into our retirement. That is how we're doing it. We are just reaching into our retirement and grabbing thousands of dollars out, which also puts us in a higher income bracket and keeps us at that unsubsidized level. So thanks for listening.
Oops. Thanks, Kelly. Okay, so Jared, I think you have a couple more slides to get through, and then we can dive into discussion. If folks have clarifying questions on what Jared's sharing, please go ahead and raise your hand. And then if you, I know folks are going to have a lot to say about Model C, so let's hold the actual discussion until Jared finishes presenting the background information.
Thanks, Jamie. I was going to turn it back over to Liz for the next slide in terms of talking through some of the potential additional policies that you could consider, because as she mentioned, you know, really what Model C has done from the modeling perspective is there's steps along the way to get to universal coverage. So they're not by any means addressing every single concern. I think a couple of the concerns we've heard from the questions here. So I'm going to go ahead and turn it over to Liz. You can go ahead and start walking through the next slide, Liz. Thanks.
Sure. I'm actually going to ask Nora to speak to this slide, and apologies for the kind of stumbling around here. It's hard with just one screen to see who's supposed to be saying what. So because Dr. Tricot, I think you made the right point. We have different populations that need a different solution, and we just wanted to talk through a few of what some of those other options might be. So Nora, go ahead.
Hi, I will not pass it to anyone else for this slide. Some of the items that have come up both in the discussions over the last year, but also were raised by some of the folks who commented on the draft report, as well as some thinking from our team. We want to add both to talk with you now, but also add into the discussion in the report of Model C. So starting with the issue of subsidies, and as we've talked about before, the work to estimate the cost of Cascade Care subsidies was going on at the same time that this work was happening, and a report just came out a few weeks ago. So we reference that in the report, but obviously that wasn't part of the analysis because we didn't have that information. That is a piece that could be added to the Model C as a full concept that would potentially address the premium affordability issue for a much larger number of folks, not just undocumented people, but other people buying through the exchange. And that would be similar to what we talked about, what California is doing, where in addition to federal subsidies, they also have a state premium subsidy. Another sort of related issue is the idea of having subsidies, particularly for people with higher healthcare needs. In some ways, this is a different way of getting at what reinsurance gets at, trying to attack the problem of certain people with very high utilization costs and trying to support them without just making a big change to the entire program cost sharing. So that's a concept that would need additional work, but is one way getting at populations with particular need. So thinking about other ways of expanding access for individuals who don't have access to affordable coverage right now, including Medicaid buy-in, which is obviously something that a number of states have been talking about and exploring. Thinking about expanding Medicaid coverage to people above childhood, particularly for undocumented folks who are not otherwise eligible. and then a buy-in similar to a Medicaid buy-in, a buy-in to the public employee coverage, which has also come up several times in our discussions. So those are kind of program expansions, eligibility expansions. Similarly, another way of getting at the issue of affordability is by having a state limit on out-of-pocket costs for low-income people in particular, that would be in the commercial market. And so that would be kind of on top of the requirements for the Affordable Care Act nationally. This would say, okay, what's allowed under the ACA is still too high, and we would set lower out-of-pocket limits for low-income people. And then to get at other ways of addressing costs that are less about individual coverage and more system-wide efforts. We've talked previously about Maryland's work doing rate setting starting in the hospital area, where all payers pay the same rates for hospital care, no matter whether it's Medicaid, Medicare, commercial, et cetera. Another way is global budgeting, where entities have a limit on how much the cost can increase, and they have to manage the care within that. And then other delivery system changes that really focus on improving quality, improving value, trying to continue to get further away from a fee-for-service system where there's incentives to just provide more and more expensive care. That's my list.
Thanks, Nora. Are there any specific question about these various ideas before we move on to the discussion? Okay.
Oh, I see Kelly raising her real hand.
Okay.
Kelly?
Sorry. Thank you. Any kind of idea about how much these would cost and what the appetite is for paying for these programs, these Band-Aids?
So Jared, can you speak about the costs? I know that was supposed to be on the slide that I stole away from you. So can you say something about that, please?
Yeah, so Kelly, we don't have cost estimates for each one of these, you know, in terms of a menu, kind of a way to phrase this. I mean, the difficulty with some of these policies or these approaches is that they are significant projects in of themselves. You know, depending on the direction for the policy, the populations impacted, the programs that ensure the populations impacted, population shifts, take-up rates, et cetera, they are all impacted on policy and parameters that are determined through any of these. And so I think we can't simply just tell you it's going to cost this or it's going to cost that, but they all independently would you know, represent pretty substantial projects in of themselves.
Mm-hmm. And how many of them involve private insurance companies versus public?
I think you could, all of them would probably involve private, just given what we walked through in the list there. But I'm not going to say that as an absolute.
Okay.
Yeah, Jared, what I would say is that because Model C was built as building on what exists now, none of these are an attempt to do the kind of system replacement that A or B does. They're all about transitioning from the existing system.
To what?
Well,
yeah.
I think that's the question, right? Like, we've had conversations previously about whether C is an end state or whether C is a transitional state. So, you know, I can't say what it would be. If it's a transition, it's a pathway, and if it's an end state, then it's changes to the existing system.
Mm-hmm. Great, thank you.
I think there were a couple more hands up.
We have some more hands up.
Yeah.
Yeah, I've got it. So Aaron, followed by Patrick, followed by Dr. Tritko. Aaron?
Thanks. I'm just sort of unclear what we're doing here. So it is just sort of following up on Rod's point. Are you proposing, or are we talking about this sort of being added to the report as part of Model C, even though it sounds like you're not going to be able to do any additional cost estimates? Is that what this is about?
Yeah,
Do you
the
want to
idea
answer it, or
is
do you
to
want me to take
include
that one?
additional, is to include additional information and thinking. But at this point, we can't do more modeling.
That's rough.
And I'll just add to that, Erin, that given that work group members are going to be taking this survey later and ranking the 3 models, this discussion is also hopefully going to provide you with enough information and some deliberation amongst work group members on Model C that you feel like you can make an informed ranking.
Okay, thanks.
And I think the other thing too, Jamie, just to chime in here, can you hear me? Sorry, is to just make sure that people know, because I think Dr. Turco did ask the question about what are the different things that need to be done. There are things that can be done building on the existing infrastructure is I think part of what we're trying to demonstrate here. We can't cost it out, but for people that are interested in knowing what something else might look like, there are solutions that have been considered, and this is just a beginning list of it. So go ahead.
And then finally, I think it's worth repeating that this is also a response to feedback. Liz said this earlier, but I think it's worth repeating feedback from multiple work group members that Model C had not received as much discussion as some of the other models, and that more discussion was needed. So next up is Patrick, followed by Dr. Tritko, followed by Jane, followed by Dr. Kovar. So Patrick.
Thanks, Jamie. Just kind of quickly here, I noticed a couple of the bullet points talk about subsidy programs, or more specifically, they talk about that coupled with cost sharing. And while it's not an exact science, there is information now available about what some premiums at least would look like for lower cost sharing, particularly for those individuals that do have higher healthcare needs and utilization. The Cascade Care program and the Center Benefit Design efforts that HCA helmed have looked into that to some extent. And if folks want to take a look at the gold level standard benefit design plans that are now available through the exchange, those give you a pretty good idea of what premiums would look like in a situation where there is very little cost sharing, very low deductibles, and that can be compared to prior years premiums or to the non-standard plans that are still available on the exchange. So while it's not an exact science, not modeling that would apply necessarily for this report, there are some good indicators of what changes in premiums look like based on trying to address those very concerns through existing efforts that I think have been successfully launched by the Healthcare Authority.
Up next is Dr. Tritko, followed by Jane Beyer, followed by Dr. Kovar.
Well, 2 quick questions. Again, going back to the undocumented immigrants, you said 120,000. I just want to know why not 170, since that is the estimate. And my second question is the 560,000 uninsured in the OFM report. Do we have any information about them? Do we know what percentage of those people qualify already for Medicaid or qualify for full subsidies under the Affordable Care Act, federal subsidies? What information do we know about them? Because I just don't see how we cannot model that. It's a fraction of what you're doing in Model A and B. That way we could make a proposal next year for all of those people to get coverage somehow.
So just on a informational bit, the OFM report doesn't lay out, the public information on the OFM report, I should say, doesn't lay out who those people are and what their income level is. Obviously, if they have lost, people who have lost insurance because they've lost a job, they may be in flux income-wise, but I don't know whether or not the OFM has collected income information on those people.
And I think also going back to the
Okay.
question about the 124,000 folks, it was again in alignment with information provided to us from OFM.
And
or
I'm
published by
just
OFM.
curious, I can't see the participants because I'm sharing my screen, but is our OFM representative on the call today? Jamie, can you see? I don't know.
I'm looking. I do see Sue's hand up. I wonder if Sue
Sure.
maybe can shed some light on this.
Yeah, that would be great.
Sue, hopefully I'm not putting you on the spot here. Oh, I lost her. Why don't we come back to this, if that's okay. And for now, let's go to Jane Breyer.
You're not
Jane, you want to go ahead?
unmuting me. Yeah, okay. So a couple
No,
of
no,
things.
we can hear you.
Okay, so a couple of things. First, I do think that OFM, in analyses that they have done on the uninsured population in Washington state, have looked at uninsured folks by income. So they might not have super recent data, but I'm pretty sure historically they've looked at that. And then this is, if information like this in terms of what's on the slide is to be incorporated into the report, the legislature passed House Bill 2547 last session, which gets a board together. It's the Healthcare Cost Transparency Board. And so with respect to legislation to address costs, I think what we would want to do is somehow note in here that the legislature has already passed legislation to do transparency and reporting around total cost of care and set an annual expenditure increase cap.
Okay. Thanks, Jane. How about Dr. Kovar?
You know, I share Aaron's confusion of what we're doing here, but I just want to make the observation. When we came to this table in that first meeting, second meeting, there really was a feel, this was before COVID. The whole group, the consensus was comfortable putting C aside. But having said that, you know, Dr. Trico's comments are just so poignant. They're so spot on. There's so much confusion. And there's such a large number of unaccounted people here between that spread of 200 and 560,000 people. I suspect that many of them would look like Kelly, where they're dipping into they have to dip into their savings, mortgage their homes, do all kinds of horrendous shell game to try to move forward. And it's not just based on their income. So I think what's happened is the desperation of the last 9 months has created a situation where we just have to feel like the legislature can do something to address the left outs here, which is initially, I was willing to put that aside and engage in the A versus B, but it absolutely has to happen. But I don't think it can come from here. It's basic. It's a basic function of government to solve this problem. And I can't believe the legislature won't grapple with that. So having said that, you know, I agree. I think it should be cost out, but I don't think it should derail us from the larger conversation around delivery system reform.
Just a quick comment. I think that Sue may have some comment on the big gap. I know there was an issue trying to unmute her before. There's always a bunch of folks who are eligible who don't enroll, I know, in the Medicaid world, and I'm sure the same applies for the exchange coverage as well. And then there's the issue of affordability. And Jason Brown, who is our OFM representative, is not on the call today. So we can follow up with OFM on that. But Sue, do you want to try to speak up now?
Yeah, I think I'm unmuted now.
Yeah, we can hear you. Yep.
Yeah,
you are.
Jane covered the important comment about the total cost of care work that the commission will be taking on, and that group will be getting seated in January. So I think it's really important in the report to link that topic. And I do think the points are well made about the economic realities that COVID has cast upon us. And so in particular, option C, and because of the national climate with the Biden administration, we're already hearing about their incremental approaches and what they're going to allow. So I think both of those things are important to point out to the legislature and to, well, certainly understand their economic impact, but I worry that the Medicaid caseload is already growing so significantly that when we catch up to what those counts are, it's likely we will be over 2 million on Medicaid for the first time ever. So I think, you know, there's just certain realities with this legislative session, given the political climate and given the COVID climate that we're in, that really will limit this. And so I do think it's very important for us to put in these themes of these potential policy connections.
Thank you, Sue. And I agree with the making sure that in the report we try to point to existing or ongoing efforts that are parallel. And I know that in the transition plan we did connect to some of those things because they're happening anyway, and it's important for these groups to inform one another. So thank you. That's a great comment. Jamie?
Liz, I'm just going to jump in here because I heard Dr. Kovar also mention that there's still some confusion about what we're trying to accomplish with this conversation. We do have some specific discussion questions we want to ask you, similar to the ones we've asked in the past about what you think about Model C and whether it's an end goal in its own or a step toward Model A or B or none of the above. So we will get to that, but I do see a couple hands up and I want to make sure we get a chance to get those comments or questions. So looks like Aaron has his hand up here. Aaron?
Thanks. Yeah, I want to sort of follow up to Sue's point. I think the current economic and pandemic crisis it needs to be highlighted, although I have a different perspective than Sue has about what this crisis means. But this is a comment I made in writing on the draft that there's no sense of urgency in the way the draft has been written to date. So I really urge the team to make sure that we're taking the opportunity of this crisis, which is shining such a light on all of the weaknesses of our healthcare system and also our economic system, that it should speak to a sense of urgency, which as it's drafted now, it doesn't. The different perspective that I have from Sue is just that crises are the time to make bold steps. Mm-hmm. I think somebody said something about the feasibility criterion earlier in our meeting, that it's a prophecy, it's not a projection. And if we choose to shy away from bold steps, it will be a self-fulfilling prophecy.
Okay, Representative Macri, unmute you here.
Hi, hello. Can you hear me?
Hello. Yes.
Yeah, this is all very helpful, and I've really appreciated this particular part of the dialogue. I may be showing my hand here, but I can really only look at Model C as a step on the path to really to Model A, which is my preference to reveal when we do that survey. But what's been really helpful for me through this process is in part the transition plan that you laid out, and all the pieces that we're discussing now, both what it has been in the works, the efforts the legislature has taken, all of the background that's laid out in the report, particularly in the post-ACA era. This is the first time we've had this amount of information laid out. So while it does not give us the, you know, here's out of the box how you address what is typically a very politically challenging problem. It does give all the tools to build that path. So my observation is that some of this work can happen in a work group like this with a diverse group of interests and stakeholders. The technical work that the consultants, including the actuaries, have done has been tremendously helpful. And I think this conversation helps clarify in my mind really how to, as a lawmaker, how to use that transition plan. The piece that I cannot do, that I'm hearing inklings from others who are commenting right now, and I actually would very much appreciate hearing from other stakeholders, the ones, and I can see you now, who come to my office most frequently during session and call me routinely about your health system interests, because I'm hearing mostly from sort of the advocate community right now, is, you know, I think just adding the pieces we're talking about now into the transition plan helps. The piece that we can't do in this committee that I think is so essential is to create that political will that folks are talking about. You're sort of directing these comments to those of us here on the work group and the consultants, but the audience for a lot of these comments are the legislators, right? So there needs to be a strategy that creates the urgency that we're talking about. I'm not sure to what extent a work group that is convened by the Healthcare Authority can create that kind of political will. So that's just a comment on that. The one thing that I also think would be helpful, in addition to the great comments that we've heard from a number of folks, is the hidden costs. So the legislature is going to be facing many struggles that Washingtonians are dealing with right now. Access to healthcare, this sort of state of health of Washingtonians being just one part of that. You know, for instance, more people in Washington state paid their rent in the last few months using their credit cards than using unemployment insurance. And so my point here is that there are hidden costs, and when we do this cost analysis, what we're not seeing is that those 560,000 uninsured, those thousands more underinsured, as Kelly pointed out, are bearing the cost of this. So it gives us sort of a false narrative of what the actual costs are and what the potential costs and or savings to the state could be. One of the things that's attractive to me about taking a step to Model C on the path to Model A is that it helps clarify what the actual costs are. We're not bearing those costs right now, but Washingtonians are certainly bearing those costs. They're just not visible to those of us in the legislature. So I just wanted to make that comment, as I think that's an additional important thing to add to this. But my overarching comment is that as a legislator, I find this report actually really helpful. And I call upon the passionate commenters thus far to, you know, do the work that can't happen, I think, in this work group, but must happen in order for us to really move towards a universal system that will cover all Washingtonians. So I'll leave it at that.
Okay, thank you, Representative Macri. Looking to see if there's any other hands up, because we have some questions for you. Liz, is there anything else more? Okay, nope, I think we're good to ask the questions. Are you ready to ask the questions? Okay. Great. So, Liz, do you want to explain the first question, what we're getting at here?
I think, we have such wonderful expertise in this work group, and we have this menu from the slide before. So our first question is really, are there other ideas or proposals that you think need to be on a menu for something like a Model C?
I see thinking faces, so we'll give people a minute.
Yeah, spend some time thinking about that.
Okay. I see Kelly. Let's find you, Kelly. Second. Oh, you're unmuted. Good. Go ahead.
Thank you. I'm a little dismayed by this drill down on option C because there's a whole other, 2 other work groups or subgroups or something that are working on option C. And that really wasn't the directive of our group. And I don't think anybody quibbles that there is an immediate need for these steps that you've outlined on that slide to be taken. No one's disputing that. Well, our question here today is, what is the end state, the desired state? What is our goal? It is not making an argument against option C happening right now. It is underway. Those Band-Aids are a go, and there's group studying how to best do those Band-Aids. So I just wanted to get that emphatically on the record.
Thank you, Kelly.
As a beneficiary of those.
Pam, I see your hand up.
Yeah.
Okay, Pam? See if I can get you unmuted here. There we go.
Thank you. I appreciate it. I'm very sympathetic to what Kelly's saying. I don't think that anyone thinks this current health system is an end state. That would be, I think a lot of us are working really hard every day to make it not be the end state. But I would like on Model C that I think, we could be doing more, especially if we're looking at Model C as a means to get where we want to go. And people shouldn't be paying $27,000 for their family to get health care. There are things we can do in the interim to relieve that. Subsidies is the obvious first step. But there's also, I think with the new administration, there are also opportunities in terms of reinsurance. The cost sharing reduction money that went away 3 years ago that had a big impact on people's premiums. We are not doing reinsurance in this state, but federal reinsurance would be a huge help for affordability. These are just things I'm just kind of thinking off the top of my head, things that we could do to stabilize, to make healthcare more affordable, and also look at groups that are disenfranchised from the current system. For example, the family glitch, people who are expected to get healthcare from their employer that is unaffordable, but the exchange would be affordable. So I just think we should look at those, make sure those things are covered. And we're happy to, Joan and I could work to submit any comments that you would want us to help with the report. But I think if we're going to look at this as a means to an end, it should be do everything we can to make the system work as well as possible as while we work on a better system.
Thanks, Pam. So I see Dr. Tritko, and then Dr. Weinberg, and then Bevan. Dr. Tritko, get you unmuted here. There you go.
So our charge was how to develop a universal healthcare system that's affordable to Washington residents. Model C does not, as it currently exists, does not do that. It excludes the 560,000 people without insurance. And it does not include the 200,000 people in the exchange for whom healthcare is not affordable. If we're not going to include those two populations, Model C does not fulfill the criteria of universal healthcare. As for moving forward, when you think about all the people that are uninsured, and if everybody in the work group and if every legislature would go in under open enrollment and look at your options under the exchange, then I think we could see what the problem is. And the question is how do we fix that, and how do we provide relief starting next year for people that are currently suffering? And that is Model C, which we haven't completed. But as for getting to B, which would be the next step after C, the only way C is really going to help that is if we somehow develop a public option that is very large. A public employee, public option, a large plan with 1 to 2 million people in it, where we can get global budgeting, We can get, you know, risk sharing. We have purchasing power, and we have statewide networks. That's how you get there. But if C is just kind of expanding the current cascade care, I don't see how that would help us to get to B. Thank you.
Darn it. Thank you, Dr. Tritko. Next up, can you hear me? Saying I'm muted still. Next up is Dr. Weinberg, followed by Bevan, followed by Dr. McGough, followed by Aaron. Dr. Weinberg?
Yes, thank you. 3 things. First, somebody has shut off my video and I can't turn it on. So sorry that you get to look at my name rather than my face. Oh, now I will do it. Okay, that takes care of.
Oh, see. Okay,
there.
Looks like that
takes care of that one. The second comment, just remember that premium subsidies, what do? They send state money, our taxpayers' money, directly to insurance companies. Is that what we want to do? Okay, and my third comment is, I really want to lean hard on what Representative Macri just said, that we need to set an ultimate goal, like option A, that the ultimate goal would be to be like the rest of the developed world and have a government-run, tax-supported system that covers everybody just because they're here. Model C gives us some ideas of some things to do in the meantime for people who are hurting badly right now, not in general, but also even worse because of COVID-19. So I see it as a, we should be making a recommendation for Model A, but these are some things that should be done, and they're included a lot in the transition plan that Optimus put together. That's
Thank
it.
you, Dr.
Thank
Weinberg.
you. Thank you.
And it will be really interesting to see what the results are of that survey that we're going to be doing shortly to respond to your comments. So Bevan, and then Dr. McGough, and then Aaron. Bevan?
Thank you. So I want to echo what Dr. Tritko is pointing out, and of course, Dr. Weinberg, and just point out that if we are going to agree as a work group that option C is a stepping stone, then we need to make sure that it is a state administered stepping stone. So from my, personal perspective, the larger the risk pool, I think we all know this, the larger the risk pool, the more cost effective a program is. So what I see missing from, at least what I've seen on the page here is a proposal for a state administered program. Now we can say that might be going through, Medicaid through HCA. We could say that that's going through something like Molina, right? Or, maybe it's a small version of option B, right? Or taking a SEB or PEB and expanding that to a much larger population. But if we are going to say that option C is that stepping stone, then we have to make it that stepping stone. And I absolutely agree with Dr. Weinberg. And this, I testified on this on Cascade Care last session as well, is, we are going to be spending state dollars and subsidies when we could be investing those hundreds of millions of dollars into a program that offers coverage to those who don't have it right now. And we can look at a population size and continue to expand that over the next however many years as we do form a pathway to option A. So I think that's really where I would, if we are going to flesh this out more, I would really like to emphasize that it is a state administered program. And we actually, and then I'll be quiet, but we do have, private groups in our state operating right now. We have Molina, we have Kaiser Permanente, we have some others who are, equipped, if we want to go this route, to contract with the state to administer, to help provide the care that a state administered program could start with. So I think there's room for creativity in this space. I think there's room for creative thinking, but it has to be state administered if we're going to get to option A through it. Thank you.
Thanks, Bevan. Up next is Dr. McGough, followed by Aaron Katz.
Yeah, thanks. So just answering the questions, first, I am a longtime and strong supporter for what's contained in Model A. And what I appreciated about the long discussion was really going through, a lot of the details. What would it look like? And sort of having a common understanding of what a universal single payer system would look like. The challenge, of course, has always been how do we get there? And having watched the intentional destruction of our current healthcare system over the past 4 years, we have a lot of work ahead of us just in the coming year to try and help patch some of the holes and reach out to the people that really have suffered. But I think the big responsibility and opportunity here is Model C, is a logical next step to getting to Model A. And that's always been the big question in many people's minds. How do we take apart a system that's in place and replace it with a radically different one? And I think even though the political environment is always tough to call, I think that Model C allows us to really move things forward. It's always possible that we freeze in place, but I think really helping shepherd this along, sort of solidifying whatever coverage we can expand now, and then really use this as the foundation to move forward to what's contained in Model A. Thank you.
Thank you, Dr. McGough. Okay, got a lineup of people. And may I just say, I actually appreciate this. Many of you are answering all of the questions we have on the screen, and that's fine. We don't need to go in particular order. So please just continue to share your thoughts, both on if there's anything else that needs to be on that menu that Liz referred to earlier, and also, do we consider Model C an end state in itself? Why or why not? Is it an incremental pathway to Model A or B? If so, why or why not? Please continue to do the great commenting you're doing and answering all of these questions. So up next is Aaron, and then I'll call on Dr. Kovar, then I see Beth Johnson, and then Vicki Lowe. So Aaron, go ahead.
So let me try to summarize a few things that my colleagues and friends have said. And I'm going to do this, in a patently selfish way, which is to sort of state my desired outcome here. And that is, people have talked about, sort of the desire and necessity of continuing to make progress in getting people affordable coverage in the state. So that's sort of Model C, and I've appreciated fleshing it out. Rod has encouraged that, and I think that's been a great advance at today's meeting. But I think we've also heard that there is a strong desire for a reachable goal that some form of Model C can bring us to. And in my experience, the thing that is most difficult to get the legislature to do is to state that and make a commitment to that goal. So for me, Model A is the goal, and what I want to see the legislature do is commit to it in a date certain, and to build the infrastructure in the meantime so that Model A is a viable outcome. So models, I'm not suggesting that this happened in the work group's report, but the Model C that I think we need to be pushing for is one that builds the infrastructure for that end state. So that infrastructure is not only populations, but it's bureaucratic and administrative structures, it's payment mechanisms, it's the whole swath of actions that need to take place if we're going to get to Model A. So Model C is, and this is why I like what Rod was pushing for. It's the Model C that builds towards that end state, not just any Model C.
Aaron, I think I'm going to hire you as a facilitator. That was a really helpful summary of what we've been hearing, so thank you. Let's see, Dr. Kovar, followed by Beth Johnson, followed by Vicki Lowe. Dr. Kovar?
Aaron, thanks for clarifying that, well articulated. I really wish we can run this tape back and quote, really capture Bevan's comment. I think that is so incredibly important. I read very carefully the last batch of public commentary that was sent to us. I listened very carefully to the public testimony out there. We should really recognize that there is a split there between people who desperately need healthcare access and coverage, and they're not necessarily thinking about whether it's delivered by the state or it's delivered through an intermediary, insurance company. And in my heart, I really think that that's the issue. Of course, we have advocates that really want to cut out the entire insurance industry as a matter of principle. Where I stand through this process is that the state doesn't have the wherewithal to do this whole thing on their own. But I'm going to have to vote, right? I'm going to need to put myself on the line. I recognize the risks of doing that, because really what Bevan said is that we need a state administered program, and that meets the criteria of a universal delegated administration. And then the answer can be between A and B, because this isn't just, all you have to do is remove the profit motive out of the insurance industry and look at it more as contract for third-party administrative services, which I think that the structure that exists now can be done rather than starting over from even as a goal of starting over, and that the state develops its ability to deliver this service. I just don't think it's a starter. So I think that if you're equipped to contract with the state, that we don't have to eliminate other kind of entities. And I want the legislature to grapple with that, to say that, yes, we're committing by date certain to provide universal coverage, and whether we take on the administration or delegate the administration is where the deep dive has to happen. And I think the legislature should be very well equipped to take that on. So anyway, again, Bevan, thanks for articulating that, because what it really says is that there's space between A and B. And if we all have to, I would just put that in my comment section when I have to put my vote, because I don't want to go, frankly, I don't want to just commit to one or the other. But I want that gray zone between there that leaves absolutely clear that we need a state administered program intact.
Thank you. That was really
Thank you,
well
Dr. Kovar. I appreciate everything you said. Oh, go ahead.
Oh, I was
think
just
you
gonna,
know the same thing. You go first.
No, I was just going to say that I remember back a couple months ago when Aaron and Jane both talked about the different examples they've put forward around the Health Services Act. I think that's what it was, Aaron, and the kids coverage example. There was a very explicit goal at the beginning of the strategic stepwise multi-year effort. So it's been done. So go ahead, Jamie.
I just want to jump in and say I appreciate all the comments everyone's been provided. We got a couple more hands up and then we'll do a time check. Do want to just say, I know it's just semantics, but I'm going to kind of harp on this a little bit, which is the survey is not a vote because we're not a voting body. So we're collecting your individual perspectives, and just want to remind everyone of that so we're clear on what the expectations are here. Beth and then Vicki. Beth?
Yeah, hi, Jamie and work group members. My internet is spotty, so if I fade, just move on from someone to someone else for the next comment. But anyway, just want to kind of build on the comments that were immediately preceding me. Certainly, Dr. Tritko's, Dr. McGruff's, Dr. Kovar's, and others about how do we get where we need to get to. And one of the curious I have in this whole process is the wherewithal of employers, to participate. Certainly we have a lot of, very prominent employers here in Washington, the Amazons, the Microsofts, the the Boeings and others that use their, oftentimes their employee benefits as retention efforts and attraction efforts. And then so many of the collective bargaining that has a certain benefit level as part of someone's compensation package and benefit package on a go-forward basis. So I think we do need to understand that segment of our state's willingness to participate in something as multi-state, international businesses. I'm not defending, our system of employer-sponsored, insurance. I'm not suggesting that's the best way to go, but that's the system that we're in right now. And I think it'll be difficult for some of those to transition. So absolutely support whatever avenues that we can take to universal coverage. But I do think we're going to need to somehow bring some of those voices into this conversation as a way to move this forward. And so I am thinking the practical way to get most people covered in the shortest amount of time is similar to what others have said, what Massachusetts and Hawaii and others have done, is to really, just kind of look at, to Dr. Tritko's comments, who isn't yet covered? How do we get them covered as we continue to move toward what makes the most sense for Washingtonians and what will Washingtonians support? But I have been really gratified and humbled by the passion and the dedication that the work group members have towards this. And I think it's something that everyone as part of this should be proud of. So thank you.
Thank you, Beth. Let's see. Vicki, it looks like you lowered your hand. So any more comments before we move on here? Timing is beautiful, everyone. Oh, no, sorry. I missed you, Vicki. I apologize. Vicki, go ahead.
No, it's okay. I had to switch to my phone because my audio on my computer was not working. Yeah, I just want to support, the things that Bevan and Aaron and Dr. Tricko said, that, Model C, get people covered who don't have access right now, and use that as a path forward to get to Model A. I think also building the infrastructure as we go is really important, because that will they'll keep us in a forward motion. I think many of us are worried that if we go with Model C and something happens in the legislature, that we'll get stuck with just Model C and not get that forward motion. So we want to make sure that Model C is a step, but the end goal is really Model A. Thank you.
Thanks, Vicki. Okay. See, one more hand up from Aaron, and then I'd like to just check in and see where we are if we want to. We're getting close to our stretch break time, and then I'm going to kind of find out from you if we want to continue some discussion after stretch break or move into your breakouts. So, Aaron?
So what I'm going to say now is that the audience may be mostly the legislators who are in this meeting, and that is that Model C, that is continuing to plug gaps, is clearly the easiest one to contemplate because it's kind of what we do, but it's not sustainable. The history, and Jane and others who've been around as long as I have will attest to this, is that we will not be able to afford coverage expansions if we do not create a system that is more efficient and is able to control spending better than the current one. We will hit other recessions when the next pandemic hits or whenever. And when that happens, the legislature will cut benefits, beneficiaries, whatever, to save money. So just to say that, to put an exclamation mark on, the strategies in Model C are only useful to the extent that they help build towards a more efficient system.
Thank you, Erin. And I was just going to briefly summarize what I think I'm taking away from this conversation. Liz, others add if we need to. But I'm hearing that many work group members are seeing Model C as a pathway to universal coverage, a pathway, but not just any Model C, one that actually addresses lack of coverage for so many people and addresses affordability. And we need to have a clear goal and pathway for getting to universal coverage. Liz, do you have anything to add to that quick summary before we, okay. So we're at 2:55. We're going to take a stretch break momentarily, and we still have our survey to do. But I wanted to check in with work group members to see if there's any other topics that we need to cover in our last conversation in the large group. Does anyone have, and thank you, Bevan, yes, and that it's state administered, that's a good reminder. I'm looking to see if there's any hands. So here's what I'm going to propose we do.
I do see two hands.
I see
Amy,
Dr.
You got it.
One person's hand up is not a work group member, so
Okay.
I'm not going to call on that person, but I will call on Dr. Weinberg. Dr. Weinberg? Wait, there we go.
Thank you.
Go ahead.
I'm a little disturbed by the comment that we are, quote, not a voting body, unquote, and therefore there is no need, nor should we record by name of the work group what they're supporting. I think that is important information because we do have people on the work group whose job it is to take a particular position. We also have people on the work group who are officials in the state who may feel that they can't express themselves as individuals. So I'm just a little, and in the name of transparency to the legislature and to the general public, I'm a little concerned about waving off the idea of a on the record vote.
So Dr. Weinberg, let me just clarify. We are going to be recording everyone's name, organization, and responses on the survey. What we are not doing is reporting aggregate. So it's not a majority rules body. And we've been really clear about this since September of 2019 when we did our charter. This group was not representative, in other words, not having been elected by peers to vote. So we are not a voting body, but we are absolutely, the survey you'll see on the questions, everyone's going to be putting their name and organization in there. Hopefully that assuages your concern.
Right.
All right,
Thank you.
Great. So I think what we're going to do is we're going to take our stretch break at 3, just 5 minutes. So everybody can stand up, move around a little bit, and we're going to come back at 3:05. We'll do our survey, and then we'll give you your time in your breakout groups. Okay, so actually I'm going to give you a little bonus 2 minutes because it's 2:58. If everyone can be back here, cameras on right at 3:05, we'll get on to the survey. Okay, thanks everyone.
is the 5-minute break. And then it goes for another hour. About 4 o'clock, and then they're pretty good about.
Okay. Looks like everyone's coming back to the table here. We'll just wait for Liz to turn on her camera because she has all the information about the survey. Give folks a second to get on. Right. While we're waiting for Liz to jump on, I'll just, for the benefit of our public guests, I'll just make sure they know what's happening. So we're going to do the survey, and then our work group members are going to move into breakout rooms. And it's going to be a little different from previous times where we're not going to have a breakout discussion in the main room. They're all going to be in virtual rooms. So we won't be, the rest of us will be in here. And we'll be recording those, so you'll be able to watch them later, but this is just going to be their time to talk about, I think, building on Representative Macri's comments earlier, what's next for each of them. So when we get to that point, you're welcome to sit and stare at us, or you can go and do other things, and we'll all reconvene here at 3:50 to do action items and next steps. And if Sue's able to join us, she'll have probably some goodbye words. And I think some of the rest of the project team would also like to say a few words too. So that'll be happening at 3:50. All right, Liz, I'm going to stop talking and let you explain what's happening next.
Sure. So you can see my screen, right? Okay. Oh, you can't see my face though. Sorry. Okay. So as we said before, we've created a survey for folks to rank order the different options that we've been talking about, the different models. You will be required, you can only select one number for each one. You can also say, I don't have enough information or none of these, but there's also a free text section for you to put in more information. For example, the conversation that we just had, I like Model A the best, but I think that Model C is a good pathway. So there is an opportunity to do that. And we're going to give you the link in the chat box to do this. And we'll also be sending it out after the meeting because we know there's some folks who are not here today. So anyway, go ahead and take a few minutes to complete the survey. It's in the chat box now, and we're going to play this music to provide some nice ambiance while you do it. Uh-oh. Oh, why does it keep doing that? Jamie, you have to let me know when we've had enough time because this will go on for 10 hours, as you know.
I was just going to suggest maybe we stop the music so they can concentrate. I think they got the idea.
Okay. All right.
Not that I don't love the Jeopardy sound. Thank you. Okay, I'm looking at faces, and it looks like most work group members have their cameras on. done, please, why don't you give me a, use the raise your hand if you need a little more time. We can certainly wait a little longer. Checking to see if anyone's got their hands up.
I see Dr. Weinberg using the old-fashioned raise hand.
Okay, all right, let's give folks another couple minutes. I don't want to rush you all. Okay. Dr. Weinberg, are you good or do you need a little more time? Okay, I think you're telling me you're okay. Anyone else need more time? Great. All right, thank you everyone. So now we want to, as we said before, give you time to spend with each other. You've been doing this work all year, and this is your last time to all be in a virtual space together. And so we wanted to put you in some rooms to just have a more unstructured, free conversation about how each of you plan to carry on with this work moving forward. And you won't have facilitating staff in the room this time, so it's be a little different than our past breakout conversations. But Sean, Mia, and Tamara from HCA will be going to the breakout rooms with you only to record the conversation. We're recording for transparency purposes. It's really important for our public meetings to record everything. But what they're going to do is just go ahead and hit the record button and then turn off their camera and turn on their mute and let you all have a conversation. Looks like it's 3:16 now. We're all going to come back to this room at 3:50 to do next steps and action items and say goodbye to each other. So you have, what is that, about 35 minutes to spend in breakout rooms together. And as a reminder to our members of the public, you're welcome to stay here and stare at us for the next little bit, or you can turn off your cameras and do something else and come back at 3:50 for action items and next steps. Any questions before we move into our breakout rooms? All right. So New York Liz, you ready to send people to their rooms? There we go, I think. Great. All right. I'm going to go ahead and turn my camera off. I'm waiting to make sure everybody goes. Oh, yep. So
there's still a couple work.
Like we still got a couple more people.
Work group members that need to go. Yeah.
So Liz, we need to put Dr. Tovar and Dennis Delwell in rooms. You could just put them in any of the three rooms.
1 minute. Yep, will do.
Okay, thanks. They're very important. We have to have them part of the conversation. Thanks for your patience, guys.
For Richard Kovar, he should see a pop-up in his screen to join.
Dr. Kovar, you see that?
You're muted.
I'm unmute him so we can talk. I got it.
Yeah, I can't. I'm just seeing the launch meeting screen. It went back to that after the survey.
Oh, okay. Give me one.
That's weird. Yeah, we can see you and everything.
Yeah, I don't see you. I just see the launch meeting button is not enabled.
What about Representative Delwo? Is anything? He's okay. What's going on with his?
Let me unmute him.
Okay.
So I think Dr. Kovar is already assigned to a room, and because he's already assigned, I can't assign him.
So maybe does he need to log out and log back in? Do you think?
We can try that. Yes. I tried moving him to another room, but it's not working.
Sorry, I'll log out.
No.
This is,
okay, thanks, Dr. Kovar. Sorry about that.
Considering
Hopefully
how many.
This is the worst tech problem that happens
Yes.
today. Okay, I'm assuming that means you left. There we go. Okay.
Okay,
Did you wear a tie
let's
for
wait till
us,
he
Jane?
gets. Sorry, I see him now. He moved to room 2. He's in room 2 now.
Oh, everybody's in a room. All right. So everyone, you can have a little time to stretch and rest, and let's all be back here. If you want to do some exercises, let's all be back here at 3:50 for the wrap up and goodbye. I think Liz has some good graphics to celebrate our.
It's like one
our
picture. Okay.
All right. I'm gonna turn off my camera. All right. Welcome back, everyone. I hope that was productive for all of you. See you. Liz, do we have everybody back? Just want to make sure we got all of our...
Yes, they all should be back or popping back in.
Oh, awesome. Thank you. On their way back in. All right, wonderful. We have a couple more things to cover in our final few minutes together. Liz Argent is just going to go through. She mentioned earlier you're going to have another opportunity to review the next revision of the report because we're putting some more content in per your feedback on the previous version. So Liz Argent's going to walk you through that, and then I'll turn it over to Sue for some final words to all of you. So Liz?
Sure. So in response to a lot of the feedback that we received, and also just because we spent some more time discussing some of the process issues, we know that it's important that you all have another chance to review the report. So this is just our timeline for how we're going to make that happen. So we'll be incorporating the changes